Before I get started, could I have a show of hands of those who are still using paper records in some aspect of their practice? All right. How about folks who are using them everywhere in their practice? All right. And among those who are using electronic medical records, how many folks use the Epic system? Okay. Thank you. All right, so for the next half an hour or so, we're going to turn from looking at and trying to understand and treating maladies in individuals to thinking about care of groups of patients in health systems, and also thinking about how could we do better in terms of taking care of patient groups in an entire region. And so we're going to try to look at the issue of using electronic medical records to improve care, and I hope at the end of this half an hour or so you will agree with me that we're at least looking at some evidence of progress. The objectives are to describe how an Agency for Healthcare Research and Quality funded trial, the DIGIT trial, which was the Diabetes Investigators Group, a study of information technology, how that trial led to a region-wide EMR catalyzed quality improvement effort funded by the Johnson Foundation, which is called Better Health Greater Cleveland. I will initially describe how the electronic medical records were used to design the DIGIT trial and provide decision support for taking care of folks with diabetes. To summarize briefly the results of that trial and to discuss a few lessons learned from that, which were then used to help us design a series of investigations, which are primarily observational, to use electronic medical records in the Better Health effort, which includes public reports to improve region-wide care and outcomes for 3 diseases now: diabetes, hypertension, and heart failure. I'm going to primarily focus on diabetes to be parallel with the DIGIT study. I'll discuss a little bit of hypertension, won't deal much with heart failure in this talk. And to look a little bit about the electronic medical record quality difference in the context of this regional collaborative. The goals of the DIGIT trial, which overall was 3 years, and there were 2 years of active intervention, were to determine the effect of this electronic medical record-based clinical decision support system on care and outcomes of adults with diabetes. We looked at 5 ADA measures of processes of care, 5 intermediate outcome measures. We did this within the context of a cluster randomized trial. So this is a smaller, system-wide, more rigorous investigation. And in that, we will look at the results in the 2 arms of the trial. We'll also look at some secondary analyses among established and new-to-system patients. The incentive, or at least the reason for looking at this new-to-system patients, is that this study that overlapped, that went into 2008, at least in Cleveland, the recession apparently started a little early because we really had a large, I work at a county hospital, we're the safety net institution, and we had a large influx of folks who were losing their jobs and losing their coverage, and so we wanted to look at this group separately. So to look at the process standards, we're going to look at the proportion of patients who had hemoglobin A1C done in the last 6 months, LDL done in the last year, those who had been screened for renal problems or were already on an ACE or an ARB, folks who had had eye exam in the past year, and whether or not they'd had pneumococcal vaccine. The intermediate outcome standards were the proportion of folks who had a hemoglobin A1C less than 7, an LDL less than 100, systolic blood pressure less than 130, BMI less than 30, and when they were screened for smoking, that they were in a non-smoking status. So the Metrohealth system has 10 practices, including 2 in the main campus site. And we needed to come up with a way of having folks in each of the arms of the trial that were balanced. So we needed to have 2 clusters that would divide up the 10 practices. We had about 100 primary care docs, about 8,000 patients, and we needed to eventually have them divided up into 5 groups. This was done by taking the electronic medical record data, looking at an extensive amount of clinical and visit data, things that we thought were related to likelihood of adherence or risk of outcome differences. The investigators looked at all of these various combinations after doing some statistical analysis. The fellow who did this for us, Tom Love, gave us 8 options of the ways that these practices could be divided into groups of 5. And we were basically asked to trade off, do you want race to be a little better balanced, or do you want hemoglobin A1Cs to be a little better balanced, and those kinds of things. All this was done blinded to which practices were in the clusters. Once the clinical folks basically said, we think this will tell us the most information, we flipped the coin, and we said this group gets the intervention, that group does not. This is a map of Cuyahoga County. Cleveland is in this central area, the most heavily populated with these 11,000 diabetics, but as you can see, Metrohealth also takes care of diabetics from all over the county, and at that point we were also seeing some folks outside the county. It's a racially diverse population with about 59% non-white. The pluses that you see are the practice sites, and then there are 2 practice sites at the hospital noted by the H. We also have a good deal of diversity relative to payment source. Medicare and commercial 63%, and over a third Medicaid and uninsured. So after doing this statistical manipulations and flipping the coin, this was what we ended up with. 5 practices in each, about just over 2,000 patients in each group. The racial balance was pretty evenly distributed, as was blood pressure, hemoglobin A1C, whether or not they were on insulin, and the slope in A1C basically means that people were, in general, getting a little better over time. The populations were, hemoglobin A1Cs were diminishing a bit over time. Those slopes were about the same. We decided a priori that in a cluster randomized trial, it's virtually impossible to balance everything. So you end up having to do some amount of statistical adjustment at the end, and we had a priori plans to do statistical adjustment for baseline differences. The clinical decision support intervention itself included filtered alerts that were linked to orders. I'll show you an example of that in a minute. And also weekly performance feedback, and I'll show you an example of that as well. So if you had come to your practice in the morning and opened your chart for your first patient, this alert might have popped up, and it's a best practice alert that says, consider prescribing an ACE inhibitor or an ARB because the microalbumin is higher than 30. So the microalbumin is 34. That was done fairly recently. We'll assume this was sometime maybe early 2005. We see that the creatinine hadn't been measured for a while. The potassium hadn't been measured for a while. And let's look about what do we know about this patient? Well, she has diabetes. She's coming to see her primary care doc. We know her kidneys are leaking some protein. Based on current evidence, we don't have any evidence that she's had creatinine or potassium problems, but these values are a little old. She's not currently on an ACE inhibitor or an ARB and has no documented allergies to them in the record. And we know there are several drugs and doses that we could use for this. So one of the things that might be done is that you might click on this and just order an update of those 2 and then make a decision as to whether or not you think that those levels are satisfactory to go ahead and start an ACE or an ARB. Every week in your inbox you would receive this report, which is an EPIC report. Some people may recognize the screens, in which, and these are actual data from one of our practitioners in one of the suburban sites. So for this particular person, they have about 100 folks with diabetes as compared to 6,200 at this point in time in the system. Has fewer women in the practice, about the same ages, has fewer African Americans or non-Caucasian patients, and you can look at the other measures that have to do with A1C, LDL, and so forth. One of the other things that could be done is that you could click on any of these and sort. You could go to a list of your individual patients and sort them from best to worst. Let's say that you were interested in looking at A1Cs. You could click that and see your entire panel ranked from highest A1Cs to lowest, or lowest to highest, however you want to look at it. And you could do that for each of the individual indicators. So these are the numerical values. What we see here is the proportional, the percent of folks with diabetes meeting these ADA criteria. And we could say that, well, we're doing a little better here in terms of hemoglobin A1Cs. Maybe we're not doing quite as well with cholesterol or ACE and ARB use. If we say, well, you know, comparing this to the system is interesting, but what I really want to know is how am I doing compared to the guys I work with. So you could click this and basically look at how you rate how you're currently performing relative to other folks in your practice, which would presumably be a more homogeneous set of patients. So now we're going to cut to the end of the study. We've done this for 2 years. Everybody's had at least 6 months of follow-up. And I might mention that everybody in this sample have been diabetics who have had at least 2 visits to the practice. So we're looking at patients who are basically committed to the practice, and that we're viewing them as basically being continuity patients, as opposed to all comers. When we look at the entire sample and look at the process of care, the point estimate is above 1. It's at 95% confidence interval overlaps with 1. So it's not statistically significantly different. And outcomes look like that they're not really much different regardless of which system was used. Looking at the new patients, it looks like that we've got a statistically significant improvement in the practice aspects of care. In other words, the actual ordering things that docs have control of. But when it comes to looking at outcomes, the new folks still were not doing all that well. Probably the strongest statement is to say that we've got very good evidence that they're not doing better. Statistically, you would say that they're not doing any differently than in either of the groups. So we have a little bit of evidence here that the process of care may get better, and that the outcomes in terms of intermediate outcomes aren't terribly different. So what are the lessons learned from this particular study? One is that we learned a lot about doing large cluster randomized trial. And one of the lessons is that stuff happens. You set up the study, you do it as rigorously as you can, you start the study, and then the world goes on without you. Changes happen, and in the general point is that in a cluster randomized trial, it's difficult to control what's going on in your own institution, and virtually impossible in terms of what's going on in the rest of the world. In the middle of this trial, one of the local foundations gave one of our sites, one of our inner city sites, $1 million a year to improve chronic health outcomes. And obviously diabetes is a big part of that. And as it turned out, we had to exclude that site, and which means we had to do a lot more statistical adjustment at the end, because our very timely and rigorous efforts to balance things in the 2 groups that had 5 practices was now history. The other thing I think to be learned from this is that this relatively conventional clinical decision support effort is really something that is good for providers. Everything that was available in the intervention in terms of information was available in Epic. Docs could go look at any of that stuff that they wanted. The problem being it wasn't organized and it wasn't directly linked to an ordering system. Although the docs could look at anything they wanted to, they could order anything they wanted to. So having this available was something that seemed to help clinicians do a better job, but was not something that seemed to help on the patient end of things. We think that much of what we do with patients is extremely important, especially in terms of chronic disease management. But we know that they spend, maybe 99.9% of their lives away from us. And it's really what happens in that 99.9% of time that really makes a difference in terms of their long-term outcomes. So one of the things this says is that helping docs do as well as they can with the information that is available is probably useful, but we still have another set of things to tackle, challenges to tackle when it comes to helping people with chronic diseases improve their behaviors and try to get better outcomes. In terms of use of this, the providers, when we asked them at the end of the study, should we continue this or not, they overwhelmingly voted to continue it, and now we're 4 years out and it's still being used. So we're now going to turn to this larger study, and we're going to try to use our experience that we gleaned from this smaller, more rigorous study to a region-wide electronic medical record catalyzed collaborative for quality improvement for chronic conditions. And again, it's diabetes, hypertension, and heart failure. We're going to primarily talk about diabetes. Twice a year, we use the electronic medical records to report how well each of these systems and the individual practices, how well they're doing. And they're not labeled. Everybody knows where they are, but they don't know who all their comparators are. One of the advantages of doing this, as opposed to using insurance claims, obviously to have an insurance claim, you've got to have insurance. Well, there are probably 20% of the people we take care of are uninsured, so they always get left out of these sort of policy-related investigations. And this effort has the advantage of always including everybody, because if you've got a medical record on them, they can be reported. The other is the richness of the medical records for comparative and adjustment purposes, which generally aren't available in the insurance claims. In the collaborative, we have these learning collaboratives, which are every 6 months. In the learning collaboratives, there are national speakers that come by to talk to us about what's going on in the various areas of interest. There's also data sharing, and one of the things that's turned out to be very helpful in these settings is to have practices which are doing particularly well share with others how do you do that. So one of the early ones was pneumococcal vaccine rates in terms of giving it to people who were eligible. One of the sites had a 95 to 98% compliance with that. Other sites were as low as 20%. So the question was, how do you do it and why aren't we doing well? Well, the site that did this actually did it by turning it over to the nurses. Had standing orders. If the person wasn't allergic, had an indication for it, and didn't have any contraindications to it, they just gave it, which makes a lot of sense, and from a systems point of view, helps docs take care of what the patient's there for, which is usually some acute complaint. And these things that are much more routine can be handled by folks who are very capable of doing it. The other phenomenon is called practice coaching, and this is basically a set of efforts to address specific issues or specific endpoints that a particular practice wants to improve, and there are special folks who go out and try to understand what's going on in this particular practice. How can we help them do better? So this is part of a national network aligning forces for quality of communities, Robert Wood Johnson funded effort. You can see that there are a bunch of folks here in the Midwest and several other institutions on the coast. This is a map of Northeast Ohio, and you can see that stretching out to Lorain County and down to Summit County, which is Akron County, and over to Geauga County and up along the lake. The systems that are involved have practices over a wide range of Northeast Ohio. We're going to look a little bit about the diversity in this. I'm going to highlight only some aspects of this, such as in the 29,000 folks who have diabetes, which included all the 48 primary care practices and 8 health systems, the range of values for being uninsured went from 0 to 100. So there are some practices and some systems that basically don't take care of uninsured people. And there are other practices in Cleveland that basically, literally, take care of the folks who have serious mental illness and live under bridges, and none of them have any insurance. We can see that there's a great deal of racial diversity, from 4% non-Caucasian to 98%. Incomes in the over the region are fairly high. Cleveland itself we're making progress. We're now up to only the 3rd poorest city in the United States. 3 years ago we were first, a couple of years ago second, now we're way up to 3rd. So we've got a great deal of diversity in terms of both indicators of socioeconomic status, median household income, and graduation rates. These are the individual component standards. We're going to primarily talk about diabetes. So we're down to 4 that the collaborative agreed on for diabetes: blood sugar testing done, testing for kidney problems, annual eye exam, and pneumococcal vaccine. Intermediate outcomes are basically the same ones that we talked about, except now we've got a blood pressure of 140 over 80 as something to shoot for. These are the heart failure related ones, but I'm really not going to spend any time on heart failure today. This is a comparison of the proportion of patients meeting standards, and all of these patients are obviously within certain systems, and the systems either have paper records or electronic medical records. So these are the paper record systems. These are the electronic medical record systems. And we can see that in terms of achieving all 4 of the diabetes care measures and the 5 outcome measures, places that have electronic medical records are doing better. If we look at the specific aspect of high blood pressure control at the level that we talked about, 140 over 80, again, those who have electronic medical records seem to be doing better than those who have paper records. This is a look at this across time, from the first set of reports in late 2006 to the last one in 2010. We see that in terms of the proportion of people who are meeting the standard, we've got a positive slope, so we seem to be doing better in the region relative to the process measures, the things that docs can do. In terms of things that patients have both an opportunity and some responsibility for, we can see that those had a relatively sharp initial response, but we continue to have this gap between what we do in a process way and what we're measuring in the intermediate outcomes. But the good news is the slopes are all positive on those. Another way to think about this is to say, well, let's look at how individual systems or individual practices were doing relative to their outcomes, and looking at that relative to the process measure, so that everybody at the 0 point would start here. Where did they go over this 2007 to 2009 period? And you can see in general the sites are improving relative to both care and outcomes. We have some where we've still got some work to do, but in general it looks like that this effort is associated with progress. We'll now turn to the question about whether or not practices using electronic medical records do better, improve faster, and does this occur for all patients? Before we turn to the data associated with that, let's think a little bit about some of the aspects that have to do with cost and quality. First of all, the federal government is spending an enormous amount of funds to have EMRs available and adopted and used. And there is an expectation that there would be an increase in quality associated with this investment. If we look at the data that were available prior to a couple of recent publications, we would find that there have been some positive results. Group Health in Seattle and Geisinger in Pennsylvania both published that when they went from paper records to electronic health records, that several things improved. They didn't have concurrent controls of folks who had paper records. There have been some widely cited negative studies. These have primarily come from the National Ambulatory Care Survey, which certainly by this point in time are dated, and frankly the survey data from the National Ambulatory Care Survey are really not methodologically up to answering the kind of questions that we're interested in. We also don't have a lot of data on what are being called the priority primary care providers. Many of those are safety net providers for whom the EMR adoption is supported by the Health Information Technology Regional Education Centers or Extension Centers. So now we're going to look at both achievement, how well we're doing at some point in time and how well we're doing over time in the process of care outcomes and in the intermediate outcomes among the systems that primarily use electronic medical records and those that are paper-based. And all these are adult patients with diabetes. We're going to look at that overall and stratified by insurance type. We're going to look at the composite standards for care and outcomes as well as some individual metrics. In these analyses, we're going to look at the outcome of interest is the proportion of patients meeting composite standards, and by that we mean whether you got all of the 4 standards for a process. If you didn't get them all, then you don't meet that criterion. And whether you got 4 out of 5 of the intermediate outcome standards. That would be measured, counted as compliance as well. We're going to use a weighted general estimating equation approach, basically because we have patients that are within systems, and that clustering needs to be accounted for. We're going to look at Medicare, Medicaid, commercial, and uninsured insurance types. We're also going to look at some census data that is basically census block data. We've got addresses on all the individual patients. We can know what the income and education levels and other census-related information are about those neighborhoods and have some idea about neighborhood resources and the general socioeconomic status of patients, at least based on what neighborhoods they live in. These are going to be adjusted for sociodemographics and language preference, and will account for the clustering. We're also going to look at some secondary analysis that are going to help us understand a little bit about what's going on with the priority primary care providers, which are primarily the safety net folks. So here we have adjusted differences in the proportion of patients meeting the standards between the electronic health record, electronic medical record systems and those who are using paper. And we can see that the difference between that favors electronic health records, 35% for all patients, and in the safety net group, about 30%. In terms of the intermediate outcomes, both of those are statistically significantly improved and the difference favoring electronic health records both for all patients and among the safety net folks. Here I would like for you to look at the basic patterns across insurance types. We've got Medicare, which for reasons you can ask me about at the end if you want, about why we think why folks may be doing better there. But Medicare has generally done better in all of our analyses, whether we're looking at processes of care or intermediate outcomes. With others, certainly the electronic health records being better than what's going on in the paper record systems, but again, less impressive with the intermediate outcomes as opposed to the process measures. Here are specific quality standards, the process measures, and the intermediate outcome measures. So whether we're looking at whether or not the A1C was done, whether we're doing microalbumin screening, sending folks for eye exams and sending folks for pneumovacs, places that had the electronic health records did better. And all of these are heavily adjusted analyses. In terms of the intermediate outcomes, the only one that we seem not to be doing better on is reducing BMIs, which is probably, I mean, diabetes. Doing better in diabetes in general is hard enough, but trying to reduce weights on a population level is just hard, and we don't seem to be doing any better than anybody else. Now we're going to look at similar patterns about these are adjusted over time. So these are a 3-year period that are annualized. We can see a similar pattern where if we look at all patients for process or all patients for outcomes, the point estimates are favor the electronic health record systems. More consistent results for care than for outcomes across all of the insurance types, and again, at least for trends over time, Medicare folks sort of leading the way, not as true relative to outcomes over time. So what can we say about what we've learned from these efforts? We can say that electronic health records were associated with better achievement of standards, that the changes appeared to be faster in the electronic health record systems compared to those doing paper, that this was true across payer types. It was also true across all standards of care and most of the outcome standards, with the caveat being that this was just adults and we just looked at diabetes. And that it happened within the context of a regional health improvement collaborative. So what we've discussed so far at least leads to some potential optimism that the incentives that are being thrown at practices to improve their EMR adoption and the meaningful use thereof, that those may in fact improve quality of care, at least within the context of a regional health collaborative, which is where the data come from. This investigation doesn't directly look at issues of cost. These are not cost reduction studies, nor do we have data that tell us about year-over-year changes in the same organizations before and after the EMRs have been adopted and or before and after meaningful use. One last piece of data I will show, and frankly this is a little bit of cherry picking. We have from 2007 to 2010, the federally qualified health centers, mainly the other safety net institutions and entities in Cleveland, had paper records until roughly 2009. And from 2009 to 2010, they began to migrate to electronic health record use. And we can at least see, in terms of reducing disparities for eye exams among diabetes, evidence that's consistent with the notion that the electronic health records help us do a better job of that and may well help patients do better as well. So I thank you for your attention, and go Tigers.